let's make a start then. We've got an hour. So welcome to GP Trainee Teaching Lockdown Learning Session 2, the virtual national VTS, if you like. Okay, so just a very quick introduction in case any of you didn't either attend last week or haven't been to one of our courses or met me before. So my name is Dr. Muhibur Rahman. I'm a portfolio GP based here in Solihull in Birmingham, and I'm the medical director of eMedica. So I split my time between doing my clinical roles. So that includes being a partner in my own practice, working as a locum in different NHS practices. And then I've just recently, actually just yesterday, got the contract through, got an honorary contract with South Central Ambulance Service to be a GP for 111. With the current pressures that they're under, you can imagine the amount of call volume they're getting through 111. And I'm the medical director of eMedica, so I spend a big part of my time teaching and training medical students, doctors, GPs, GP trainees, and so on. That's my clinic, that's my room. You can see we have a sort of camera set up there so that I can do remote consulting if I need to, and so on. The things that we're going to cover today, we're going to go through some important topics from dermatology. We're going to look at a few things from child health, and we're going to look at careers-wise, salaried GP jobs, pros and cons, and some things to know about them. Okay, and then there'll be a Q&A. I will take questions at the end, if that's okay, because that way, if people haven't got questions, I can finish in an hour for them. They can head off, and then I can stay back and do questions for another 10 minutes or so. Okay, so let's make a start with dermatology. We're going to look at three important areas. Now, remember, both in AKT and CSA, you get a mixture of those things that are really common everyday general practice. So things like acne, eczema, they often come up, but then also things that are less common but more serious, like skin cancers. So we're going to look at these three areas. Okay, so if we start, let's go straight into a question. Have a look at this question. I'm just going to turn my camera off while we do this. Have a look at the second one, because if I tell you the answer to the first one, it might make the second one obvious. So just do the second one. Okay, so now if we go back to the first one, key things in this first one is that this is someone with mild acne, okay, predominantly affecting the face, never been sexually active, and all she's used is just a regular face wash, okay, nothing medicated, just normal face wash, all right. So most suitable initial treatment. So you could have a case like this in CSA, someone just come, they're embarrassed, they want something help with their acne, and then in AKT, this is how you might get a question presented. They have up to 10 answer options, which makes it difficult, okay, in AKT. So correct answer for this one is A, topical adapalene. Okay, now that was not one of the most popular answers, so a lot of people struggled with this one. All right, if we look at what people put into the chat and then what people put into the sort of the poll, this was up there, but it wasn't the most popular answer. So let's look at why. First thing is that mild acne, topical therapies are first line, and so we could get rid of all of these ones, D to J, we could get rid of. So you're picking either A, B, C. The reason B and C are wrong is you never give topical or oral antibiotics as monotherapy. If you're going to give an antibiotic, whether topical or oral, to reduce the risk of resistance, you want to give something else topical with it. So for example, you might give topical clindamycin or erythromycin with benzoyl peroxide as a combination. That's fine, okay? But you wouldn't just give a topical antibiotic. All right? And orals, therefore, second line for mild or first line for severe acne. So that's why A is the right answer. So we'll go through the guidelines for managing mild acne. Topical therapy is recommended first line. So if you're going to give monotherapy, your choices are topical or retinoid. So things like adapalene is a topical retinoid. You wouldn't give that if they're pregnant or breastfeeding, but this girl was never sexually active, so she can't be pregnant. Okay. Or an alternative is azelaic acid, 20%. And then if you want to give combination therapy, that's okay. But the options are either a topical antibiotic with benzoyl peroxide. You don't give a topical antibiotic on its own, or a topical retinoid with a benzoyl peroxide. So there is a combination treatment with both adapalene and benzoyl peroxide in one gel. Okay, so all of those will be fine for first line treatment of mild acne. Okay, now the second one, this one is what we call a multiple best answer. So those of you that did it last week, I introduced you to this. If you haven't already sat the AKT or you haven't started looking into the question formats, so one of the question formats is multiple best answer, where you have to get both of them right to get 1 mark. Let's say you get 1 right and 1 wrong. You wouldn't get any mark at all. You don't get half marks in the AKT. You either get 1 mark or you get none. So you need both to get right. So key things here, this lady's got severe acne on her face and back. She's used topical benzoyl peroxide with no improvement. And then she's got no significant past medical or family history, non-smoker, blood pressure, body mass index, all within healthy limits. Okay, so which two are the most suitable? Okay, now most suitable is a relative term, right? In terms of exam technique, watching out for these keywords, really important. Suitable means suitable for this patient in this scenario. So at this stage, which two would be okay to give to this patient? The correct answers are E and H. You'd need both to get the mark. It's not that you're going to give them both at the same time. You could either give an oral antibiotic with a topical therapy, or you could give the combined oral contraceptive pill, given that she's sexually active, and or even if it doesn't mention about that, but the fact that there's no contraindications to have the combined oral contraceptive pill, you could use this. Why would you not use the progestogen only pill? It's not one of the options here, but anyone want to type that in the chat? Why would giving someone with acne, let's say they are sexually active, why would giving them the progestogen only pill not be sensible if they've got acne? That's, in this case, it's severe. Any thoughts on that? Yeah, absolutely. Because the progestogen only pill can often inflame or exacerbate acne. So the last thing you want if someone is trying to get treatment for their acne is that it might make it worse. Okay, so you wouldn't want to give them something like that. If we look at some of the other options, oral isotretinoin, laser therapy. Oral isotretinoin is for severe acne that's resistant to medical therapy that you've tried in primary care. We didn't start oral isotretinoin in GP. So for example, someone's tried antibiotics with something topical. They've tried the pill. It's not worked. You might refer to dermatology for oral isotretinoin. Laser therapy can be used in severe acne with scarring, but it's not a licensed treatment. So again, that would only be secondary care. So it wouldn't be something that would be suitable at this stage. The other option that's here that maybe some people might have picked, so some people might have picked oral limacycline, D. The reason this one is inappropriate is, we mentioned earlier, you don't give that on its own. You need to also give a topical treatment. And then G, oral cociprindile, is licensed where someone's got moderate or severe acne and they've tried oral antibiotics and it's failed. So at this stage, they've not tried oral antibiotics, so it's too early for G, oral cociprindile. And then F, limacycline and topical clindamycin. Whenever you give an oral antibiotic, you always give something topical with it, but not a topical antibiotic. You don't give topical and oral antibiotics together. So you could give oral limacycline with topical benzoyl peroxide, or with adapalene, or with azelaic acid. You need something topical that's not an antibiotic. Okay, so E and H. Well done to those of you that got that right. Okay, so in terms of severe acne, first line is a tetracycline orally. So it could be doxycycline, limacycline, tetracycline, oxytetracycline. All of these, as a class effect, are fine. What's not recommended is minocycline. And in terms of practical terms, what I tend to use in real life is I tend to use limacycline. Why? Because I try to learn for each class of drugs one thing that I know well and I know the doses, but also if I'm going to pick out of something once daily or twice daily, think about the kind of people that we're giving oral antibiotics, for severe acne to. A lot of them are teenagers, right? They're busy, they've got hectic lifestyles. If you give them something that they need to take twice a day and they're just busy and they forget, a lot of times they won't respond, not because the drug doesn't work. They don't respond well because they're only taking half a dose. They're taking it once a day. They forget to take it twice. Whereas once daily, they're much more likely to be able to take the full dose, right? Okay. If they can't tolerate tetracycline, then erythromycin is a suitable alternative, all right? If there's no contraindication to having the combined oral contraceptive pill, then think about the UK medical eligibility criteria. We will do a session on contraception in a future session. We'll look at that, okay? But then that's an alternative. Whereas cosiprindile, which is a hormonal treatment that we might use, for example, with someone with hirsutism or male pattern baldness and things like that, it is licensed for moderate or severe acne, but only where oral antibiotics have not been effective. So it's not first line. That's why it wouldn't be the right answer for this particular question, okay? Right, let's look at a case now, the kind of thing that you might get in CSA, for example. So this particular one is a telephone consultation, which is one of the types of things that we all having to do a lot more now, right? Okay. So the patient here is actually Jason Thompson, R.E. Jordan, i.e. Jordan's the patient, Jason Thompson's likely to be a relative, okay? In this case, it's the dad, okay? But that's one of the things that you might verify. And then it tells you, okay, the setting. So in this case, it says you're doing a telephone consultation. Sometimes it will say you're in outer hour. Sometimes you say you're doing a routine clinic or you're doing a home visit, things like that. So what do we know about him? Well, have a quick look at that. I give you a minute or so to quickly have a look at that. Okay, so I'm going to be the father, all right? Imagine that we've gone through, you've answered the phone, you've check that I'm the father, I've told you I'm the father, and that it's about Jordan Thompson. So we've just done that just to save a bit of time. Just type into the chat some of the first things that maybe you want to know about this patient. Okay, what are some of the questions that you're going to ask? I've opened with, look, doc, you've got to refer me to a skin specialist. This skin's driving my son crazy, and then he's driving me crazy. Can you just refer me, please? So that's my first question that I've asked you. So what would you like to ask? I'll be the patient and I'll answer your questions. Okay. Let's see who's going to kick us off. Please put these in the chat, okay? Not in the Q&A. Okay, so the first question someone's asked is, are they well? Yeah, he's well in himself, except he's itching all night, so then he's not sleeping, he's crying. And then that wakes me up because I have to go there, put some cream, settle him down. Then I can't get back to sleep. Then he'll start again. So then I'm really struggling with both work and dropping him to school. Okay. Someone's asked, has he got any allergies? Well, not particularly. I mean, obviously, I think that some things irritate his skin. That's why his eczema sometimes get flared, but not any particular allergy. Like, he can eat everything. Nothing particular. Someone's asked, is there anything different than before? Not really. I mean, when we came last week, it just got really bad. And the doctor gave some steroid cream. We've had steroid cream in the past, and usually it helps, but this time it's really not made any difference. It's not even a bit better. And as I said, he's scratching it so much, it starts bleeding, and then he cries because he gets scared, and of course it's annoying for him. And then he's not sleeping, so he's tired in the morning. Okay, so he's tired at school. His nursery teacher tells us that often he's a bit drowsy in the afternoon because he's not slept at night. So then we don't want him to fall behind at school, but it's affecting me. I'm not sleeping well, and so that has an impact on me getting ready for work on time. Someone's asked, is there family history? Oh yes, sir. So I had bad eczema when I was a child, but I've really grown out of it now. And his mum's got asthma. So between us, I know these things. The GP explained when he first got it that these things often run in families. Okay. So someone's asked about, are we giving him the cream? Oh yeah. So he's got a big tub of that greasy stuff. I whacked that on 2-3 times a day, and then the steroid, the doctor said twice. So I put it once in the morning and I put it once just before he goes to bed. Okay. How long has he had eczema? He's had eczema really since he was about 1. I think we've had first noticed it. I mean, he had bad skin since he was born, but I think, formally the GP said that we think this is eczema, and he had his first type of cream. He had like E45 cream then, but we tried lots of different things. This latest one that he's on, this is quite sort of sticky. He seems to get on quite well with that usually, but it's just not working right now. Okay. So someone's asked, how many flare-ups has he had in the last 6 months? Okay, so that's a good question. So I'd say he's probably every couple of months, he'll have one that's sort of quite bad. This is the worst one I think he's ever had. It's normally when we put the steroids on, after about 4 or 5 days, it starts improving. But we've had it for a full week and it's not really improved. And then that's why I called, because the doctor said that if it's not getting better by a week, to call in. Someone's asked her, how do I put it on? So I put on the sticky stuff first, because I'm normally putting that 3-4 times a day anyway. And then I put the steroid straight after that, okay, because I know that that's strong. So I didn't want to put that on first in case it stings. Someone's asked, has he got a fever? No, he's not hot or anything. He's just fed up. He's itching, scratching, and then it bleeds, and then he doesn't sleep. Someone asked, how many fingertip units do you put on? Oh, sorry, doc, I don't know what that is. What's a fingertip unit? Someone else asked, who's at home? Well, his mum and I, we separated. So, he stays with me part of the week and he stays with her part of the week. At the moment, it's holiday, so I'm having him for the first week. Next week, he'll be going to his mum. Someone's asked, anything changed recently? Well, the missus and I, we split up about 6 months ago. And I mean, I'll be honest, it has been a bit worse since then. And obviously, I don't know what goes on when he's at our house, but I make sure he gets his creams and everything when he's with me, all the time. Someone's asked, how's my mood? Look, I got to get on with things, yeah. I got to look after my boy. I got to earn an income. I haven't got time to be worrying about my mood. I'm here for him. So, can we just sort him out? As I said, can you just refer him to the skin specialist, because what you've given him hasn't worked. So can I just get a referral, please? Is that okay? Okay. So I'm going to stop you there. Let's look at some of the key things in the data gathering, and then we'll look at how we're going to manage it in a second. All right. So I think you guys have asked a lot of these things already. So well done. But how long has he had these in the first place? Has he had a fever? That would be a red flag that maybe he's got a systemic infection. If he's scratching and bleeding, there's an increased risk of getting an infection, right? And then a young child, if they become systemically unwell, then they might need antibiotics, right? Another good question that will help you decide, are they systemically unwell with it, is things like, are they eating and drinking, and has their normal interaction changed? Or are they quieter than usual? Are they, sort of watching TV or playing as they normally would, or things like that? So how are they taking the treatment? How often they're using it? Anything that might have set it off. So anything changed recently? Okay. We asked about flare-ups, and so perhaps we could ask, has he ever had to have antibiotics for this? Has he ever had an infective exacerbation in the past? Another useful question to ask is about recent travel. Could there be something else causing it? Like if someone's recently been to, I don't know, holiday somewhere different, there could be other things that you might need to think about. Okay. And then things like if you've changed the sort of shampoo they use, the body wash they use, the powder that you use to wash their clothes, things like that might be worth asking about. Okay. And then we also found out about the family history and then the impact on the child. So we looked at sleep, how it might be affecting school. Another really important question is behavior. Do they seem to be having any tantrums more than usual? Do they seem more upset? Do they seem like it's in fact impacted them in any other way? And we found out about the home situation. Okay. So in terms of examination, and we can't examine if it's a telephone consult, right? So one of the things you could do is sometimes, like let's say not this scenario, but let's say you thought, okay, from what they're saying, you were thinking, okay, could this be a meningitis? You could ask them to check the body for a rash, and if there's any spots there, to press a glass against it to see whether or not it's blanching or not. You can do things like that, right? But in a situation like this, one of the things that's really important is we need to see this child, right? It's one of those things you're not just going to be able to deal with entirely over the phone. So it'd be really important to ask them to bring the child in at some point so you can examine them fully, so you can, check the skin, make sure they haven't got a fever, just see, does it look infected as well as inflamed? How badly inflamed is it? Could there be something else going on? Okay, now let's say now you had a different scenario where you've seen someone and you've diagnosed that, okay, that sounds like it's typical atopic eczema, known history, and it's a flare. This patient was pushing for their son to get a referral. One of the things that's important to do is for you to know the guidelines as to when you should and shouldn't refer, so that you can manage appropriately. Because if you give in to someone just because they want a referral, if it's not clinically indicated, then you're going to lose marks in the management part of your CSA. But equally, if someone meets the requirements for referral, some doctors, they get it in their head that if someone's demanding something, they must say no. Just because someone's been awkward or difficult, don't let that cloud your judgment. Judge based on what's in front of you, on the clinical diagnosis and the current guidelines for management. So you need to know when you should and shouldn't admit or refer, when to refer urgently, when to refer non-urgently eczema. And like in this situation, if there's no evidence of infection, if there's no evidence of any red flags, then we can manage this in primary care. And it's important to me have the confidence to say that, look, I can see that you're really upset by this and it's having a big impact on you and your son. This is something we can manage because we see this a lot in general practice. Let's talk to you about how we can help you improve his eczema. And then you take back control, you see, okay? So a couple of things to think about. So one is to use the emollients as much as possible. It doesn't matter if they use it 5-6 times a day, and sometimes some children need that, okay? And then usually, if they've had a mild steroid, so hydrocortisone 1% is a mild steroid, then you'd want to try a short course, about a week, of a moderate potency. You go up to the next step, okay? Topical steroids. And anyone pick up the way that this father mentioned he's putting on the steroids, that he puts on the hydromol, then he puts the steroids straight after. You see, the hydromol is going to act as a barrier. It's fairly waterproof. That steroid is not going to be absorbed into the skin. It's one of the reasons why it might not be working. So things to say, there should be a 30-minute gap at least between putting on the steroid and putting on the emollients. Now, there's a difference of opinion between different dermatologists. Some say put the steroid first, then put the emollients. Others say do it the other way. There isn't a consensus. What they all agree on pretty much is that there needs to be that gap so that one has been absorbed before you put the other. Because otherwise you just put a barrier on, you put something else on, it's not going to absorb. So that would be important. And then looking for, any particular triggers. So someone had asked, if they were pets, for example, and then maybe, they like to cuddle with the pet in the bed or something like that, and they've got sort of irritation or allergies to that pet dander, that could set off an inflammation. So if they had a new pet or something like that, or maybe a split in time between here and the partner, that there's been a split, if they've got a pet in the other house, for example, when they come back it might be worse. Okay, so in terms of potency of steroids, so he was on hydrocortisone. Now hydrocortisone on its own, it doesn't really matter if it's 0.1%, 1%, 0.5%, 2.5%, it goes up to, all of that's mild. And again, as I mentioned earlier, look, there's lots of moderate, lots of potent, and a couple of very potent. But one of the things I recommend for your exams, try to learn one of each class that you know the details of, so that you can easily prescribe if you're having to use it in CSA, for example. So for moderate, the one I tend to use is Umivate, that's the brand name. So clobetasone butyrate, 0.05%, is one of the most commonly used moderate potency steroid, okay? Potent, there's loads of these, so I tend to use Betnavate, so betamethasone valerate. For example, you've got things like, Locoid, so hydrocortisone butyrate. You've got lots of different options, okay? And then very potent, the only one I ever use, and have ever used in 19 years of doctoring, is clobetasone propionate, also 0.05%, brand name Dermavate. Now, this one's really easy to confuse with this one. Clobetasone butyrate, 0.05%, clobetasone propionate, 0.05%. The way I remember it, I leave clobetasone propionate for the skin professionals. I don't ever start anyone on this until they've seen a dermatologist. If they've started it and they have a flare and I've seen it previously, I'll give them a short course second time. But the first time, if I've been through mild, moderate, potent and they don't respond, I get them to see a dermatologist just to make sure that, is it something else that I could be missing? Could it be a rare skin cancer or an atypical infectious disease like a fungus or something? And they can take a biopsy or skin scrapings, because what you might be doing just by giving more and more steroids is just masking it, okay? And in terms of the interpersonal, one of the things is to remember that eczema is a chronic disease. And so it can have a significant impact, not just on the child, but on the family and the carers. So it's worth giving some detailed written information for them to take away, or to access, or tell them about a useful website like patient.info. And you do need to take on board, like, it's not that there is one emollient that is better than another. My son had really bad eczema. We had to go through so many different things until we found what fitted him. And I've had patients where they've got 2 or 3 children with eczema, and what was perfect for one child, the second child, the same thing had no benefit. And something that the first child really didn't agree with, the second child, it worked really well. So you've got to try a few different things and take on board also what they find comfortable using and putting on. And just to show some empathy, that look, it's really upsetting to see your child scratching and crying and not sleeping, and that can have a real impact on the parents' mental well-being. So well done that someone asked about that. Okay, and just encourage them to keep going. That if they put as much emollients as possible, to keep going, that they're working hard, they're doing a good job, that often after the flare, things will calm down, and often they grow out of it. Okay. Now, in terms of management, emollients, as much and as often as possible. All right, you can't overuse emollients, honestly, just as much as possible. Then when they get inflamed, it depends. So if it's mild, mild inflammation of eczema, you're going to start with a mild steroid. So mild potency is hydrocortisone, okay, up to 2.5%. If that's not worked, or if it's already a moderately severe flare-up, then you might go straight to a moderate potency like clobetasone, okay, butyrate, so Humavate, okay. And then if it's very severely inflamed, you might go to a potent. All right. I mentioned that 30-minute gap between the steroids and the emollients. Doesn't matter which order, but you need that gap. And then sometimes from the scratching, they get an infection. And when it's infected, then they might need antibiotics as well as the steroids. So if it's really bad, or if they're systemically unwell, then oral flucloxacillin is the first line. If it's a small patch, not widespread, and it's just localized, topical fusidic acid is also useful. But if it's widespread, or if it's systemically affecting them, then you want flucloxacillin orally. Okay. Now, as I mentioned, this patient didn't warrant a referral just because they want it. You got to know when's the right thing. So can you put into the chat, when would be some of the times when you would either admit a patient with eczema or refer them, whether it's routine or urgent? When are some of the times when you'd refer to dermatology for eczema? Any thoughts? While we're waiting for that to come through, someone's asked, how long would you suggest to use the steroid for? Generally, you don't get them to use steroids for more than about a week, 10 days. If it's not worked by then, you want to have another look at it. Okay. So someone said eczema hepaticum. Great. That will be a indication for admission. Great. Okay. It's actually one of the few indications to admit someone with eczema is they've got widespread eczema hepaticum. Okay. What about to refer then? Like this patient didn't need a referral. When would you refer for eczema? Okay, so someone said if they're systemically unwell, okay. Someone said if they're septic, yeah, so if they're really badly systemically unwell, of course, we're going to admit them if we think they're septic. But otherwise, just because let's say they've got a bit of a fever and it looks infected, that doesn't mean you always have to admit them. You might be able to start a treatment and then see how they respond to that. But yeah, if they're really unwell with it, yeah, you're going to probably admit that child, okay? But in terms of when we might refer, so admitting eczema hepaticum, so widespread herpes simplex infection, okay? Refer within 2 weeks if they've got infected eczema and it's not responded to a full course of antibiotics. So you've given them Fluclox and it's not responded, they're still unwell, they need to be seen really urgently. And then refer routinely if they're just getting lots of infections, recurrent infections, or even though it responds, when it's there, it's really quite severe. So you want them to be looked into. Or diagnostic uncertainty, like the one I said, you've been through, they've had quite a strong steroid, still not responding, you're not sure, could this be something else, not eczema? Might it be worth sending? And then someone else said, if it's causing severe psychological impact, again, even though clinically it might not be bad, that can have a huge impact. And so sometimes seeing a specialist so that they can maybe get it under control quicker, or just to get that second opinion can be useful. Okay, great. So let's have a look at a question then about eczema management. So have a quick look at this. I'll turn my camera off. I'll launch a poll in a minute. Okay. Okay, so very interesting. The most popular answers were B and D. So 2 fingertip units and D, 4 fingertip units. These were the most popular answers. I'll just put my camera back on. So 2 and 4 were the most popular. However, every single answer option was picked. Just highlights that it's an area that people often struggle with. Okay, the key things here is that you can see, first of all, it's an adult, and that you can see both elbows and both hands, okay, are affected. All right, it doesn't look infected, but it is very inflamed. So we need to give some steroids. So the correct answer is D, 4 fingertip units. So well done to all of you that got that right. About 44% of you got that right. So well done, just under half. That means just over half got it wrong. Now, about a quarter of you picked 2. This was the second most popular answer. And a lot of you that picked 2, it might be because you forgot to multiply by 2. What do I mean by that? Well, basically, how many fingertip units do you need for a hand? 1. How many for an elbow? 2. But he's got 2 hands, hasn't he? And he's got 2 elbows. So look, 1 fingertip unit for this, 1 fingertip unit for this, 1 fingertip unit for this, 1 fingertip unit for this. So 4 in total. So commonly, what people forget to do is they forget to multiply by 2. They forget to do the second part. Okay, and that's why 2 is the second most popular answer. So when you forget to do both hands and both arms, you just think about 1. That's when you pick 2. Okay, so if we look at fingertip units, by the way, does anyone know where was the FTU, the fingertip unit? Where was it invented? Anyone know who invented it and where? Type that into the chat while I go through this. So a fingertip unit is basically all steroids in the UK. They have standardized, and actually internationally, a lot of other countries have adopted this. They standardized the diameter of the hole, the aperture for steroids. Okay, what that means is you can use that as a reliable measure of how much, because a common reason for steroids not to work is that people don't put the right amount. They don't know how much to put, and then that's the problem that fingertip units was designed to solve, if you like. Okay, so put into the chat, don't put it into the Q&A. Anyone know? Yeah, so it was in Cardiff where I trained. I went to medical school. In those days, it was called the University of Wales College of Medicine. It was Professor Finley, a dermatologist there. His wife is a palliative care consultant, Dame Elora Finley. But it was Professor Finley, the dermatologist. Actually, I did some clinics with him when I was a student. Okay, so it was Cardiff. Okay, that said, actually, although it was purportedly invented there, if there are any Asians in the audience, then actually your great-great-great-great-grandmother already knew about fingertip units. I'm going to tell you how to cook perfect rice. All right, get any container, doesn't matter if it's a rice cooker or just a pot. Wash your rice 3 times. That's the first thing, okay, to get rid of the excess starch, and then fill up the water until it is 1 fingertip unit above the level of the rice. So what's a fingertip unit? This is a fingertip unit. Right, so if you go to the first crease, so from the tip to here, so if you basically, if this bit's touching the rice, water comes to here, and then just cook it, your rice will come out perfect every time. All right, it doesn't matter what container you use, it works every time. So you know, your mother or your grandmother or your whoever cooked the rice, they already knew about that if any of you cook rice regularly. All right, but yeah, the fingertip unit, so because it's the same diameter, all steroid tubes, can you see most adults, they'll have a similar distance to the distal interphalangeal joint, okay, so i.e. the first crease. So from here to here, it's a fairly standard amount, okay, so if you're, that's 1 fingertip unit, okay, so how much do you need? Well, I've listed it there. So you know, for the genitals, you just need half. For a hand or an elbow or a knee, you need 1. So remember, if they're going to both hands, typically it's bilateral, isn't it? Eczema, when it's flared up, it's rarely on one side. Whereas if you've got like a contact dermatitis, it might be on just one side, right? Okay, so 2 hands, you need 2 fingertip units. 2 elbows, you need 2 fingertip units. 2 elbows and 2 hands, you need 4 fingertip units, and so on. All the way down to, if you're trying to do a hand and the whole arm, not just the elbow, that's 4 fingertip units, okay? Or both buttocks is 4 fingertip units, and so on, okay? So yeah, someone's saying lockdown, absolutely. You know, you're probably eating a lot of rice. It's one of those store cupboard classics, right? Okay, so let's look at dermatology now. I'm just going to put my camera off, have a quick look at this question. I'll launch the poll in a minute. my camera back on. Lots of people picked A, basal cell carcinoma, and then lots of people picked D, squamous cell carcinoma. But again, every single answer option was picked. Just again, highlights. It is something that the examiners highlighted in the last exam, that dermatology generally is an area people struggle with, but questions that involve photos and pictures, whether it's skin, whether it's an inner ear, whether it's ophthalmoscopy, people often find these things difficult. Okay, so key thing here in the history is that they've had a transplant before, and then if you look at the picture, it's asymmetrical. That straight away tells us it's not a basal cell carcinoma. Basal cell carcinomas are symmetrical. Okay, so if it's asymmetrical, we're probably thinking either melanoma or squamous cell carcinoma. And then the fact that they've had a transplant and the fact that you can see it's bleeding in the middle. Melanomas rarely bleed. This is squamous cell carcinoma, so D is the right answer. So well done, just over half of you got that right. Okay, so D. And one of the big things is that they had a transplant. So the drugs that you get given to prevent rejection after a transplant, there's an association with these that increase the risk of squamous cell carcinoma. So any new growing lesion after a transplant, we treat as an SCC until proven otherwise, and it warrants a 2-week referral. Okay, so if we look at skin cancers, the most common and the least aggressive are basal cell carcinomas. They tend to have a pearly border, they're symmetrical, they grow very slowly. So in a picture test, look at the picture, but also read the scenario. So if you look here, 6-month review after a renal transplant, and it developed a month after. So in 5 months, it's grown. Okay, BCCs grow over years. Okay, very slow to change. Squamous cell carcinoma, these can metastasize, but they're often locally invasive. Transplant patients are particularly high risk. They tend to be asymmetrical. You often get telangiectasia, and they ulcerate and bleed in the middle. And then melanoma, least common, most aggressive. They're asymmetrical with an irregular border, but one of the things that we're looking for, variegated pigmentation. Variegated means multiple shades within the same lesion. It's not just that it's pigmented. A pigmented mole is pigmented, but it's one shade all over. We don't worry about it. It's the fact that there's multiple shades of pigment in the same lesion that you see in a melanoma that worries us. Okay, so BCC, routine referral or non-urgent referral. Squamous cell carcinoma, malignant melanoma, both need a 2-week referral. Okay. Right, we're going to move on to 2 areas of child health now. We've got about 20 minutes left to cover this and to talk a little bit about salaried GP. So I'm going to talk to you briefly about some childhood infections and school exclusion times, and then drug dosage calculations, which come up in every AKT ever. Okay, we also sometimes have to do in a PEDS case in CSA. You always get at least one child health case. So have a look at this first. And I'll stop you there. Right, okay, so again, every single answer option was picked. Just highlights it's an area that people struggle with. The popular ones are D and A. So A, paracetamol, PRN only, and then D, penicillin V, 10 days. And after that, actually, it was C, no treatment needed. So out of interest, what do you think the diagnosis? This is what we call a 2-step question. The mark is for step 2, the management. Step 1 is working out the diagnosis, which, remember, we look at the picture and the scenario. So the scenario, there are 3-day history of sore throat, fever, fatigue. And then in the picture, what we're seeing is this, and then the redness on the cheeks here. Okay. So what do you think the diagnosis is, first of all? Put that into the chat, and then that will help us to work out why you might have thought the second step. Okay. So some people thought strep throat. A lot of people saying scarlet fever. Did anyone think, I'm just thinking about the people that picked paracetamol only. Did anyone think slap cheek syndrome, parvovirus, B19? Yeah, so a couple of people thinking that. So I can see if you thought it was parvovirus, why you would think, and if you just had this picture without the tongue, if you just had this picture, this looks very similar to parvovirus, slap cheek syndrome. Okay, you can get a very similar appearance in both scarlet fever and this. This is scarlet fever though because of the strawberry tongue. Okay, it's a very classical finding. You wouldn't get this in parvovirus, whereas you would in scarlet fever. It's one of the ways you're going to help separate this. The other being the very rough texture, which isn't mentioned here, but you'd feel on examination, the sort of sandpaper-like texture that's described. So the correct answer is D. First line for scarlet fever is penicillin V for 10 days. Okay, you'd only give erythromycin for 5 days. Actually, you wouldn't, because even if they were truly penicillin allergic, azithromycin is what's recommended rather than erythromycin. Okay, and if they just have a reason why they can't tolerate penicillin V, because that's 4 times a day, and a child is sometimes difficult to give, then you could give high dose amoxicillin once daily or moderate dose twice daily. You wouldn't generally use erythromycin. Okay, so scarlet fever, initially they have these non-specific features, sore throat, fever, fatigue. This patient had all of these. Then they may or may not also have things like headache, nausea, and vomiting. Then typically the rash comes on a bit later. So it's a blanching rash. It's erythematous punctuate. There's that rough sandpaper-like texture. Often the palms and the soles are spared. Okay, and then things that you might see. So they might get that slap cheek look, that flush face, and then the strawberry tongue is the classical appearance. Okay. So in terms of scarlet fever, first line is Pen V, 10 days, QDS. A lot of children aren't going to take medicine 4 times a day. So you could use high dose amoxicillin once daily or moderate dose twice daily. If they're allergic, then azithromycin is what the guideline recommends. And then you're going to advise them to take time off school. How long? How long? You've started antibiotics today. How long do they need to stay off school before they're not considered infectious? Yeah, someone's also mentioned here, you also often get perioral sparing, like you saw in that picture. If anything, looks a little bit paler around there. Okay, so someone said 5 days. Anyone think less than 5 days? More than 5 days? Someone said 48 hours. A lot of 5 days going on. A lot of 48 hours going on. So the right answer is actually 24 hours. Okay, so scarlet fever is one of the odd ones. It's one of the shortest exclusion periods. It's 24 hours after you start antibiotics. They're safe to go back. For impetigo, if you're going to give them antibiotics, 48 hours later, they're not infectious. If you're not going to give antibiotics, they need to wait until the lesions have crusted and healed before they're considered non-infectious. Measles is 4 days from the rash starting. Remember, the other name for rubella is German measles. That's also 4 days from the rash. Mumps is 5 days from the swelling, because that's what defined mumps. Chickenpox, the guidelines have changed recently. It's now until all the vesicles have crusted over. Used to be 5 days from the rash. It's now until they've all crusted over. And then all of the other ones mentioned here, conjunctivitis, molluscum, glandular fever, tonsillitis, threadworm, they don't need any time off according to public health, okay, in terms of being infectious. Although some of these are infectious, they're not dangerous, so they don't need time off, okay? And we're going to do a drug dosage calculation. Again, I'll turn it off, I'll give you the right time. You can use calculators. Please don't write your answer in the chat. And that's time. Thank you very much. I'll close the poll. Okay, so every single answer option was picked. Again, something that we know from the examiners people struggle with. The most popular answer is the right one though, which is C. So well done. Most people did get this right, okay? So C is the right answer, 7.5 milliliters 3 times a day. Let's go through the calculation. So the first thing is, this is the actual dosage of pediatric ibuprofen for a 5-year-old. And the Royal College will always use the actual dosage in the BNFC for pediatric dosage calculation. So 30 milligrams per kilogram in 3 to 4 doses, okay? First thing is to know that if the child weighs 15 kilograms and it's 30 milligrams per kilogram, we need to work out how much they need in total. So it's 15 times 30, which is 450 milligrams. And you can see you can give this either in TDS or QDS dosing, but look at the answer options, they're all TDS. So our next step is to divide by 3. So 450 divided by 3 is 150 milligrams each dose they need. Okay. Now, if the concentration is 100 milligrams per 5 mils, then if we do 100 divided by 5, we work out how much is in 1 mil. So there's 20 milligrams in each milliliter. So the last step is to work out how much they need each time. So that's 150 milligrams divided by the 20 milligrams per mil. That gives us 7.5 mils 3 times a day. Couple of common mistakes. So some doctors, they forget to divide by 3 because it's TDS dosing, and they just work out the 450 and divide that by the 20, in which case you get 22.5 mils. Okay, that's a common reason for getting that bit wrong, is that you've missed one step. And this is why it's useful. You have an on-screen calculator. We also have a laminated piece of graph paper and a board marker when you're doing your AKT, okay? Or you have note paper if you're doing your CSA. Sometimes putting down the working steps is useful, even though you've got a BNF-C in the CSA, and in the exam, in the AKT, you don't have a BNF, but you've been given the dosing here and you've got a calculator. Even then, writing these steps for some people is quite useful, rather than trying to do it all in your head in one go, okay? One last thing is do a reality check. Because they use the actual concentrations from the real BNF-C, just think, a 5-year-old, are you going to feed a 5-year-old 22.5 mils of any liquid? That's 4 and a bit spoons. Do you know what I mean? Like, they're probably going to spit it out after the second one, all right? They're not going to have 4.5 spoons of medication. That's difficult to get down a young child. Whereas 7.5, 10, you're probably going to get away with, all right? Similarly, sometimes, let's say you've done an opioid conversion, which we did last week. If your answer is 500 milligrams instead of 50 milligrams, just think, okay, if I give someone 500 milligrams, they're probably going to die, okay? Just do a reality check, because they're using actual dosaging from the exam, okay? So there will always be drug calculations in every AKT exam, whether it's, there's almost always at least one child one like this, and then one cancer type, opioid conversion one. So they're the clinical topics. The last 10 minutes, I wanted to talk a little bit about one of the career options that's really popular, which is being a salaried GP, in a bit more detail. Okay, so we're going to start by advantages and disadvantages, and then I'm going to give you an overview of some of the things you need to know, and then that'll take us to questions. Okay, so first of all, just think for yourself and maybe type into the chat, if we just focus on advantages first. Any advantages to taking a salaried GP post? Remember, a salaried GP, you're an employee. Okay, we talked about this last week, for those of you that joined us last week, that a salaried GP is, you have a fixed contract, you're employed by the practice, you don't own the practice, okay? So what are the advantages of taking a salaried GP job after you qualify? What do you think? Okay, so someone said that you can get NHS pension. You can get NHS pension as a locum and as a partner, so that doesn't separate it. So someone said that stability, yeah. So the fact that you're going to have, fixed hours. I'll come back to some of these in a bit more detail. Someone said you get paid annual leave, you get regular income, you get access to things like maternity. You don't have to worry about the running of the business. If I'm looking away, it's because I've got 2 screens. Okay, fixed salary, fixed hours, so you can plan. You get sick pay if you're unwell. Less working time than, say, a partner. Less responsibility. Eligibility for maternity pay, yeah, because you don't get maternity pay as a locum. As a partner, you may not get maternity pay. Depends on the partnership agreement. Might make it easier to get a loan or a mortgage because you're an employee. It might be a bit less stressful. For someone that needs sponsorship for a visa, that's going to be easier. Less bureaucracy, less stress. Okay, so those are some of the advantages. Let's go through some of the ones that I've got there. So, and I'll just expand on them in a bit more detail. So yeah, the fact that you've got stability. As a salaried GP, you will have a fixed number of hours you work each week, and you work the same days each week typically, okay, and the same time. So you can plan things like childcare. You can plan things like, if you're going to take a part-time salaried role and you want to do some other things, explore some other interests, you know what days you've got to do those things. So you have that stability. You get the same exact income every month. Okay, so you know how much is going to hit your bank account, so you can plan your expenses and know how much you've got to pay for your rent, your bills, putting your kids through a nice school, expenses, saving up for a holiday. You know what's coming in, you know what's going out. You have employment rights, so sick pay, maternity pay, paternity pay, all of these things. Maybe someone's mentioned, and I missed it because a lot of comments came through, but you get more CPD and education opportunities. So as a salaried GP, you should get paid CPD time. It can vary depending on the practice and the contract, but you should be getting some paid CPD. Whereas as a locum, not only will you have to pay for your own CPD and you won't get paid, you're going to lose income on that day. Whereas as a salaried, you should get that as part of your, and there can also be in-house educational opportunities. There should be practice meetings. There should be, sometimes you'll have an area, like in our area, practice is shut down or get out of hours to cover one afternoon a month, and the different practices meet, and there's organized teaching, okay? You can focus on the clinical work. Yes, there'll be admin related to your patients, but you don't have to worry about hiring and firing staff. You don't have to worry about upkeep and maintenance of the building. You don't have to worry about health and safety beyond making sure you are being, aware of your own health and safety. You're not responsible for other people's health and safety, okay? And actually, for the right salaried contract, the money can actually, in some cases, be better than a partner in a low-income practice, okay? Although in most cases, it won't be, okay? What about the other side? Any downsides to being a salaried GP? Anyone want to put those into the chat? Downsides of being a salaried GP. So someone said lower income, less autonomy, the commitment. So compared to a locum, for example, yes, you've got to have notice period. For a salaried contract, often it's 3 months, okay? Haven't got the same flexibility as a locum to do a bit less, bit more. You've got to ask someone for time off if you want to take annual leave. Yes, you get paid annual leave, but you won't necessarily get to choose when you take it. You won't necessarily get first pick. If so many doctors can be off at one time, you might not be able to get the time you want, because everyone wants time off when it's school holidays if they've got young kids, for example. You can't always decide the shape of the practice. You can't decide if you want to, your practice to start offering minor surgery and they're not interested in that. As a salaried, you might not have a say. As a partner, you could decide that, okay? And someone said that more admin than, say, a locum. Yeah, absolutely, but less admin than a partner. It's sort of in between, isn't it? Okay. Someone said that in terms of the rota, you might find that you get more than other people in terms of the on-call or the visits, more than, say, some of the other doctors in the practice. That can be the case. Again, it all depends on the practice, doesn't it? Okay, good. So if we look at some of these disadvantages then, so for a really good, there's a national shortage in the UK, right? We're probably 10,000 GPs short. Don't believe the numbers you read in the papers. It's nowhere near just 5,000. It's a lot more than 5,000. We're probably 10,000 GPs short from what we need. But actually, for good practices, salaried posts are still competitive, okay? In terms of the money, if you look at the mean income from the last set of tax data, across all salaried GPs, it was £58,000 a year, but that includes the fact that the majority of salaried GPs work less than full-time. Okay, but because the tax data doesn't gather if someone's working only 2 days a week or 3 days a week or 4 days a week, 4.5 days is considered full-time once you qualify, remember. 9 sessions is considered full-time, a session is considered half a day roughly. Lack of control, people have said, exploitation. So in some cases, as a salaried GP, you might be given more and more work or sort of pressure to stay back beyond your contracted hours, but without being given additional pay or time off in lieu, which you should be getting. But this is why you need to have a good job plan before you agree a contract, okay, before you agree a start date. Amend and agree the contract, negotiate any points in it, have a job plan, have it all written down. So then if it's different to that, you can go back to it. That's one of the things we cover in detail, how to negotiate that contract in our CCT Plus course. Extended hours. So, if you're salaried and you really don't want to do evenings and weekends, but your practice is doing it, you'll be expected to take part in the rota. Whereas if you are a partner and you're not interested in doing that, as a partnership, you could decide we're just not going to do extended hours. You have that choice. If you're salaried in a practice and that's what they're doing, you might not have that choice to say no. And so, you might find that you become the workhorse in terms of some of the things like visits and things like that. That said, for those people that have never run a business or never been a partner, one of the things that you don't see is how much admin, I've been an employee before, but I've also run 2 or 3 businesses, right? That as a partner, on average, a full-time salaried GP works about 40 hours. They're paid for about 37.5, but they work about 40. On average, a full-time salaried partner works 50 plus hours. So they're working a whole day more than a salaried. A lot of that work is the admin side and the management side, which maybe you're not seeing, okay? So it's important to understand that you might be doing more of the clinical work, but someone else is doing other work. It's not that they're doing any less work than you. Almost every partner I know works more hours than every salaried GP I know, pretty much. Okay, in terms of, if you compare, they're both contractually down as full-time, which one would work more? Okay, so if we go through an overview, if we look at the average income from the last set of tax data, it's just over £58,000, and that includes the fact that the majority of salaried GPs are working less than full-time. There's different types of GP practice contract. Okay, the four principal ones are GMS, that's the most common. It's a national contract. PMS practices have more income. So salaried GPs working in a PMS practice on average earn about £4,000 a year more than a salaried GP working in a GMS practice. This is why one of the things you want to do is look at what type of practice, when you're looking at the advert and you're negotiating, find out. That said, GMS practice has more protections in some cases in terms of the contract. If you look at the range for someone working full-time, that the lowest in the BMA model contract is just over £58,000, and there's no absolute upper limit. I've seen salaried GPs earning £100,000 plus for full-time. Now, full-time, according to the BMA model contract, is 37.5 hours, but if you look at the data, most salaried GPs are working 40 hours or more if they're full-time. And if you look at the rate per session, now session is thought to mean about half a day, but it's actually not protected term. So under the BMA model contract, a session means 4 hours and 10 minutes for planning. It doesn't mean that you can only work 4-hour, 10-minute slots. In reality, a session can be anywhere from 4 hours to 6-7 hours. There's some doctors that are getting paid for 8 sessions, so that's 4 days if you like, but each day is 12 hours. So they're really doing 3 sessions in a day. They're actually working, much more than full time. This is why you want to get the detail and negotiate and understand and before you sign a contract, because once you've started at a place, it's much more difficult to change things after you've started. In terms of indemnity, most practices will pay for the indemnity for salaried GPs, but if not, depending on how much out of hours you're doing, extended hours, whether you do, there's private work that you'll do as a salaried GP. So for example, if you're doing like DVLA medicals as part of the practice, that's not covered under NHS indemnity. And so depending on how much you do of that, your indemnity might be anywhere from about £500 to £2,000. And then pension, you pay the employee part. So for most salaried, it's going to be about 12.5%, up to as much as 13.5%. If you're working very part-time, the lowest threshold is about 9.3%. And then the practice pays the employer contribution, okay? And then one of the big things is that you're an employee, so you have employment rights. You have right to paid sick pay, maternity, paternity. You should get paid CPD time in your contract, okay? None of these are automatically guaranteed as a partner, and as a locum, if you're sick, you don't get any income. If you're on maternity, you're not going to get any money from any practice. You've got to make sure you build up some funds to cover your income during those things, okay? So that's some of the things to think about in terms of being a salaried GP. Key thing is, whatever role you do, none of them are better or worse. It's not better or worse to be salaried than to be locum, than to be a partner. It's just what's right for you. And what's right for you might be different to your friend, and what's right for you now might be different to 5 years down the line, and that might be different to 10 years. Like when I was newly qualified, I wouldn't have wanted to be a partner and the responsibility and the additional headache. But we opened a practice 3.5 years ago, and I'm really enjoying it. It does come with a lot of stress. There's a lot of additional work, but I like the fact that we could shape the way that we run our service. For example, we have 20-minute appointments. What does that mean? It means we don't make much money, but it means that we're not stressed. We have the time to do our job well, okay, how I want to do it, so that I'm not stressed out when I'm at work. I look forward to my clinical days. I look forward to seeing my patients. We could decide that as a partner. As a salary, if you say, I want 20-minute appointments, but the practice is everyone else is running 10-minute slots, you're not going to get a job, are you? Because it's just not going to be workable. But, as a partner, when we opened our own practice, we could decide things like that, okay? So, we decided that we didn't want to do extended hours, and we don't have to do extended hours. I want to do joint injections, we do joint injections. We wanted to take on GP services for a secure unit for women who are mostly sectioned with severe mental health illnesses. We tendered and we won that contract. We could do that if we want. My partner does a lot of occupational health work as part of his portfolio through the practice. He does the medicals for National Express for their new coach drivers and bus drivers and things like that. But, for some people, they don't want that additional headache. They love the idea that it's exactly the fixed income. Some months we get less income, some months we get more. Some years partnerships will do less well, some years they'll do really well. There's that uncertainty and there's that additional time, right? So don't let anyone define what is the right role for you. Being a salaried is not better or worse than being a partner. It's not better or worse than being a locum. They're just different jobs, and you're unique. Find what suits you. Okay, right. If you've got any questions, ask them in the Q&A, not in the chat, please. Okay, in the Q&A, not in the chat. I'm going to come back to questions in a second because we're just running over time. So just before we go, a couple of things to say. First of all, if you didn't already join the GP training support group after last week, I will send you the link in the post-course reading. Please do join. There's 18,500 odd doctors there, either in training or applying or trainers. I will send you the video recording and the slides and the CPD certificate by tomorrow evening. There is no session next week because next week I'm teaching 3 full-length webinars, 3-hour webinars. Tuesday, I'm doing Statistics Made Simple for anyone preparing for AKT, all the key stats in one 3-hour webinar, okay? In this format, questions, teaching, rapid reviews. We send you the slides beforehand. On Wednesday, the whole of the admin domain in 3 hours, everything that you need to get a really good score. On Thursday, high yield clinical, all the clinical topics examiners highlighted as problem or important areas from the last 10 years worth of examiners reports. These things are going to come up in the exam. They frequently get retested. That's Thursday. And then I've got clinics, and then I've just starting my new role with 111. And then Saturday and Sunday next week, I'm teaching 2 full-length webinars. So Sunday's a full-length AKT webinar. Saturday's SJT for doctors applying for training. So we will be back the Thursday after. So do register for that. 23rd of April, okay? We'll be covering palliative care, we'll be covering contraception, we'll be covering locum GP pros and cons. The timing is going to change, but then it will stay the same time for the rest of these sessions. And the reason it's going to change is that the prayer times for the evening prayer is going to change, and the month of fasting, Ramadan, is going to start. So I've got to be mindful of people that need to break their fast, but also for me as well. So from now forward, all of the rest of the teaching sessions will be 7:15 to 8:15, okay? So stats on Tuesday, if anybody wants to join, I'm going to give you a code now for a discount. Wednesday's admin, Thursday's clinical, 3¼ hours. You can use this code if you want to keep your learning going, whether it's for AKT or CSA, any of our online revision or online recorded courses, or any of our webinars. Use this code LOCKDOWN, all lowercase, and you get a 20% discount. That will expire on the 15th of April, that code, okay? So you can use that until then to get 20% off any of our things. And I leave you with this from Bruce Lee, that to succeed, long-term consistency beats short-term intensity. One of the reasons we're keeping this going a little bit at a time, and I recommend that if you are going to set AKT or CSA, try to do a few questions each day. Try to do 1 or 2 cases that you look over the guideline or practice or read, even if it's here and there. That if you just wait till the last couple of weeks and try to cram it, it doesn't work for these high stakes, high challenge exams, okay? That you want to keep it going. That said, what's even better than just long-term consistency is to add to that some intensity. That's why as we're getting closer to the next AKT, we do these sort of like 3-hour webinars covering all of stats in one evening, and then you get the video so you can watch it back again afterwards, okay? Things like that. If you combine consistency with bursts of intensity, like the last month before any exam, you need to double down on your learning, then you're going to succeed. And finally, if you found it helpful, let me know in the comments, okay? I'm enjoying it so far. I hope you're enjoying it and finding it helpful, more importantly, to take your mind off everything else that's going on. Keep you focused, get some learning in, and keep you going. Prepare and you will succeed. Thank you very much for taking up part of your evening and joining me, okay? Anybody leaving now, thank you so much, and I'll see you in 2 weeks' time, unless you're going to do AKT and you want to join the webinars next week, because I might see you Tuesday, Wednesday, Thursday, either all 3 or any of them, okay? Thanks very much.